So my name is Gary Puckrein. I am president of the National Minority Quality Forum, and I want to welcome really a distinguished group. I feel that today I'm going to learn quite a lot, so I'm really looking forward to the day. Later on this morning, Congresswoman Kelly will come by and bring some greetings. For those who don't know us, the National Minority Quality Forum has been partnering with the the Health Brain Trust of the Congressional Black Caucus to do this spring meeting for, I guess now 10 or 11 years. I know we've been doing the meeting 14. I think they joined us 10 or 11 years ago. We try to look at important issues of the day, and begin to plan action. We're always about, so what can we do to help our communities? What I thought I would start off the morning, if you'll indulge me, is to talk a little bit about the National Minority Quality Forum and the work that we do. And then later on, we've been doing some work in sickle cell, looking at some of the numbers, and I thought maybe we would share a little bit of that with you by way of an introduction to the way in which we think about problems. So some of you weren't here yesterday, and some of you were. For those who were, please indulge me a little bit as I try to explain to those who weren't here a little bit more about the National Minority Quality Forum and the work that we do. So when we got started in 1998, our focus was on the elimination of health disparities. And basically, it all started for us and many in the health disparities movement with the Heckler report in 1985 that sort of documented that minority populations, their health outcomes were different than the majority populations, that they were worse, that they were not. They had higher levels of diabetes, cardiovascular disease, their mortality rates were higher, et cetera, et cetera. And that launched a movement to eliminate those disparities. And so if you look at Healthy People 2010, the objective of Healthy People 2010 was the elimination of health disparities. But actually the conversation about health disparities really goes back to W.E.B. Du Bois in 1906. He actually did another book in 1894, in which he too documented the disparities. But back then, the issue was the newly emancipated slaves and how to bring them into the world in which they now had responsibility for their health care. And as part of that movement, Booker T. Washington launched National Negro Health Week in 1914, and it was picked up by the federal government. And if you go into the archives, actually, the University of Maryland has a huge archive of government programs related to eliminating disparities back then. And if you go back and read it, it looks like everything that we talk about today. It's amazing to see how long we've been talking about this and how much the time changed. But what happened after the war intervened, and we sort of lost sight of those goals, and it really wasn't until the Heckler report. So most of the 20th century was about closing the gap. It was about essentially using the majority population as the reference population to see if we could not bring about health equity. And so a lot of resources and time went into that effort. We joined the conversation in 1998, and we too were focused on elimination of health disparities. And as we started to do our work, and I'm going to take you quickly through some of the ways in which we sort of tackled the problem, what we began to realize is that in the 21st century, that's not really the conversation that we should be having. The conversation in the 21st century, in our mind, is about sustainability. in every sense of what that word means. That we need to be able to build healthy, sustainable communities for all populations. And the great challenge, at least the way we like to articulate it, is that we want to control health outcomes. In effect, by our admissions, we have been controlling health outcomes. When you talk about health disparities, you're really talking about a society in which we permit populations to live shorter, unpleasant lives in the way in which we distribute medical information and medical technology. It is a decision that we make. And so when you look down at those zip codes where minority populations reside, you can see the output of that, year after year after year, even though we've been sort of working at that throughout the 20th century. So what we've started to work on is, so how do we get in community and really control health outcomes and make sure, number one, that every person in every community, when needed, has access to best modern therapy, that we're really leaving no one behind. And that in itself is a huge task and conversation, as I'm sure you'll all know, because there are parts of our society that believes that everyone shouldn't have access to health care. And so that's an important conversation. And then how do we do it? How do we organize ourselves to do it? But we also mean it in the future tense as well. And in the future tense, what I mean is what we see is we're in the midst of a medical revolution in which we can and are trying to conquer these diseases. If you look at HIV, we turned it into a chronic disease in about 10 years. Pretty amazing stuff. If you look at the trend lines for cardiovascular disease, what you see is the prevalence is growing because people are surviving longer, but if you look at the new cases of cardiovascular disease, like chronic heart failure, atrial fibrillation, they're all trending downward. The challenge with all of that is that it costs a lot of money, and that's really what the fight is about. How much do we want to invest in those trend lines? And our argument is that we're really making the investment into the future, that what we're doing is we're setting the world up so that generations from us don't have to travel the same pathway. And so it's really, that's the aspiration that we have. And so when we started to think about chronic diseases in the minority community, obviously sickle cell was one of those diseases that became important to us. So, the core idea is that we want to build sustainable, healthy communities. And I'm going to jump ahead through these slides a little bit because I want to just talk to you a little bit about how the National Minority Quality Forum sort of looks at these issues, because it's important for the conversation we're going to have about sickle cell today. So we got started, as I said, in 1998, and we are a research and education organization. So what I mean by that is we do not go into community and provide care. We're not physicians, we're not clinicians. We are a research group, but we partner. We partner with those in community who are actually touching patients or touching providers. And that's the way in which we think about it. And what we're trying to do is use evidence and big data to see if we can't bring about those healthy, sustainable communities. So since 1998, we've been collecting health data. We've built a database now north of 2 billion patient records, and we're about to, over the next couple of months, hopefully, really accelerate the growth in the access to data that we have. So the way in which we look at the world is more population health, and so we're focused on the zip code as the smallest unit because of HIPAA that we can look at, and we're trying to understand what's happening at those zip code levels. And a couple of quick numbers for you that will probably help you understand why we're doing what we're doing. 38,000 zip codes in the United States. 70% of African Americans live in 2,500 zip codes. So this conversation about sickle cell is really about 2,500 zip codes, and as you're going to see, it's probably even more narrow than that. It's a really geographically small community that we're talking about. The Hispanic population, like the African American, 70% live in 2,500 zip codes around the country. About 50% of Asians are in 1,500 zip codes. So 7,000 zip codes is really where the minority population resides in the country. So we started to collect the data, not just on those 7,000 zip codes, but we did it for the whole country, and we did it without looking at any therapeutic area in particular. The challenge with big data is that you need statisticians, and it's complicated, and it's hard when you're working with cross-functional teams to share that information. And so the way in which we've approached it and how we've partnered with others is through data visualizations. In particular, we use geographical information systems so that you can visualize where the population is that has whatever the disease or disorder that we happen to be looking at. And we're not just looking at how many patients have a disease, we're also looking at and mapping who are the providers. So in many instances, we can aggregate each patient to the provider that they see. We can also look at what medications they're on, what their adherence rate is, what their outcomes look like in terms of hospitalization, emergency room visits, mortality, et cetera, et cetera. And so, and as you build more and more of this data, you get into the land of predictability. You can start predicting down at the community level what outcomes are going to look like. And so we try to put all that information. We call them indexes. Other people refer to them as heat maps. And the reason why we say index is because we're also providing charts and tables and other tools, just more than maps. So some of the key learnings that we've picked up as we've been working all of this is, number one, geography matters. I mean, if you've been at this, any of you have been at this conference over the last day or so, or even before, know that geography really matters, that even your mortality rate is predictive by the zip code that you live in. But here's what's more important, or as important, I think that's probably a better way to put it, about geography. And I use this shopping metaphor, and I always apologize to my physician friends about this. But when people have a chronic disease or any disease or need medical attention, they essentially go shopping. They go shopping in hospitals, they go shopping in clinics, they go shopping in pharmacies, they go shopping in physicians' offices. And when a disease clusters in a community, it means that the products and services that need to be used to manage that disease likewise gets clustered. And so you create a market, if you will, around that disease. And when you're looking at the numbers, what you can see is diseases tend to cluster. So numbers, 38,000 zip codes, 80% of everyone with diabetes in the country lives in 8,000 zip codes. You can go to the other 30,000 zip codes, but the real marketplace is in those 8,000 zip codes. And so again and again, you can see that. The other thing that's important is people tend to consume healthcare like their neighbor does. And so what you get is consumption patterns that are really stable. People buy healthcare not dissimilar from the way in which they buy cars or TVs or take a trip or read a particular magazine. So So you can look at a zip code and begin to understand those patterns. And as you understand those patterns, you can build predictive models. You can begin to anticipate what's going to happen in a community. I like to think there are no random hospitalizations, that they're really highly predictive. And through that way, you can manage your healthcare resources. And that's really the point of the exercise, that we want to be able to manage our resources. So let me tell you a little bit about the sickle cell story. This is just some preliminary data. We prepared for this conversation, but there's lots more that we need to learn and begin to understand, so that we are really equipped to help patients who are living with this disease. So this is the Medicare fee-for-service. I don't know if you can see all the numbers. I'll read out to you. So Medicare has two parts really now to it. It's Medicare fee-for-service and Medicare Advantage. The Advantage program has more disease management component to it, and so more and more people are moving into the Medicare Advantage. Medicare fee-for-service, you just go see your doctor. Medicare pays, but nobody's following up on your care, and that sort of thing. So we found roughly 9,700 people with sickle cell using ICD-9 codes in the Medicare fee-for-service program. We suspect that there are others in Medicaid and commercial insurance and the managed care, as I said, and we'll pay attention to that and begin to pull that data together as well. What I found interesting and didn't anticipate is that the majority of them are women. About 58% are female and 42% are male. In the Medicare program, the minimum age is 18, and so we found the youngest was 18, the oldest was 99. 18 means that you've qualified for some sort of disability, and so these folks have some disability. What's also interesting is that the median age was 39. The 75th percentile, the median age was 55. So what that signals, particularly in the Medicare population, is that there's a survival thing going on. So if we did the age pyramid, what we would find is that there's real issues related to survival going on. And we've got enough data we can go back and look at mortality patterns in the Medicare program, but I'm looking at that, and the signal is that there's probably some high levels of mortality in that population, and we should take a look. I mentioned to you consumption groups before, and so let me explain a little bit about consumption groups and the way in which we think about them. So, and we do this independent of commercial insurance or Medicare or Medicaid, whatever. We cluster patients based on how much was paid for their care exclusive of prescription drugs. So the prescription drug data is not in here, and the reason why is prescription drug data can, it's reflective of a lot of other things and not necessarily the care that was given. And so the crisis consumer group in the Medicare program, we're spending about $139,000 a year or more. And so when you look at when you're looking at that crisis consumer group, you're understanding that they're the most expensive group in the Medicare program. Among these folks with sickle cell disease, typically in the Medicare program, about 3% of the population is crisis consumers. Among the sickle cell beneficiaries, it's 11%. And so you've got a disproportionate number of them who are um, in that crisis consumer group. And down at the bottom is low consumers. You're spending less than $1,000 a year on their care. And the primary driver of that care is really hospitalizations. And so if you look over there where it says percent of unique inpatient stays, you can see that crisis consumer and heavy consumer group have high levels of hospitalizations. We looked at total use of care, but I think the main signal was that those crisis and heavy consumers we're spending a lot on them going to the hospital, and that's really what the main signal is. What's also important about these consumption groups is that they're not stable, meaning from year to year, people migrate from one consumption group to another consumption group, and they migrate at highly predictive rates. So it'll be interesting to see if that holds true with the sickle cell population. Can we see people moving from low to crisis at predictive rates? And that becomes important because as we understand those consumption patterns, we next want to put on clinical information so that we can help providers anticipate who's likely to migrate up or down. And when someone goes from crisis to low consumer, that may not be a good thing. They may be migrating down for reasons that we may want to fix. And so these consumption patterns really become the basis of analysis. So here's the geography of sickle cell disease in the Medicare fee-for-service program. We've clustered by the first 3 digits in the 5-digit zip code. The first 3 digits are the postal center, and the other 2 digits really tell you what block or street the person's on. And the reason why we have to do that, by our data use agreement, we can't show cell sizes of less than 10 because you may be able to identify someone. So we had to aggregate up. And so if we didn't do that, we'd have to withhold some of the data. And so in order to show more of the data, we did this clustering. And as you can see, it's around the southeastern part of the United States with some pockets out in the west and up in Detroit and Chicago. I also know, because we've done the zip code level look, that it's also in places in Pennsylvania. When you drill it down to the zip code, the 5-digit zip code, what becomes important is, in a state like Pennsylvania, there may be 600 zip codes, but 80% of everyone with sickle cell will be in 20 zip codes. And so it really does cluster into certain communities. That has real meaning. If you remember now, we were talking why geography matters. So what it means is, so where sickle cell care is being given is around those communities. And so we need to understand better what those facilities are, the care they're providing. It also means if you're doing a clinical trial, you want to do your clinical trial around these communities because that's where you're most likely to find patients. You may not see it, but those red areas mean at least over 100 people with sickle cell is living in one of those red areas. And so it really helps us hone in on where we need to provide care. And for me anyway, what it says is we don't have to go all over America. Our work is really in certain parts of the country. And here we just started looking at some other data, looking at inpatient days to see how that was getting distributed. And those red areas mean that there are over 251 hospitalizations. We can go in at the zip code level and calculate variations in hospital rates that may be a signal of the type of care that's being given or the severity of the disease. I'm not sure until we take a deeper dive, but already we can see variations, and so we certainly want to explore that. And here's cost, and so we sort of mapped out cost and that sort of thing. Where we're headed towards is our indexes are really a cloud-based tool where you can literally go in and map these all of these numbers, and we're really looking forward to partnering because there's lots of other data and information that's available, and the way we work is lots of data, lots of analytics. What's really helpful? What do you really need to know that helps you in the work that you're trying to do? And so that's part of the conversation down the road that we'll want to have, which is what really works for you. And I just want to close with just a couple of quick thoughts. And this is from the National Minority Quality Forum's point of view. And that is sickle cell trait and other diseases like diabetes. I know we're focused here today on sickle cell, but sickle cell trait has implications for people with diabetes, and that clustering that we see for sickle cell suggests that the sickle cell trait might be clustering in those zip codes as well. And so for physicians who are treating patients with diabetes, that's really important for them to know. And so hopefully this group will see the broader context of what sickle cell actually means and sickle cell trait actually means, and how do we educate those providers to make sure that as they're treating patients with diabetes in those communities that they're aware that the sickle cell trait may be having some impact. I should also say, in the data, we can look at comorbid conditions with people with sickle cell disease. Didn't show it, but we can go and look at comorbid conditions. And it might be interesting to see, in those comorbid conditions, are there anything that's driving hospitalizations or having some unique impact? So it's all about building sustainable, healthy communities. We want to partner to make sure that people with sickle cell disease are able to have long, healthy lives, to make sure that best modern therapy that's available right now are available to them, and work very hard to get new therapies and make that all available. So we're in a listening mode here today. We're excited. I know you guys have been working on sickle cell and pioneering and fighting in the trenches for a long time. And we're here to learn from you. We want to know how can we be helpful, and what are the next steps as we try to get about the business of building some healthy communities. So I'm going to stop there. We've got a great program for you this morning. Dr. Thompson, she's flying in, so I told her that when she gets here, whatever panel is presenting, we'll let them finish up, and she'll come in and talk to us a little bit about the great work that Ash is doing with sickle cell. So we're going to be excited to hear what she's doing. So 2 seconds. I'm going to ask Mary Houlihan to come up, and we will start the program. Thank you so much.